All right, so we're going to start our discussion on diseases and conditions of the digestive system. So this is just a quick rundown of the very basic, very simplified anatomy and physiology of the digestive system. Remember, the digestive system starts in the mouth, but it also includes the areas connected to the oropharynx, which also includes the nose, etc. You can kind of think about it as one long tube. In fact, remember, it is sometimes referred to as the alimentary canal. So, diseases of the GI tract. Just as a quick preface, I will be skipping over things that have already been covered in previous chapters. So you'll see some things that are in the text that we've already covered for various other reasons. So when we look at diseases of the GI tract, they really affect our ability to absorb, ingest, digest all of the substances the body needs to actually function correctly. We get all of our nutrients through this tract. We get all of our energy through this tract. Okay, so we ingest food that contains macronutrients like your protein, carbs, and fats. Those get broken down in the body and either stored as various different substances like glycogen or adipose tissue, or they get processed into ATP, or they get they essentially go straight through the digestive tract. So there's a couple different broad ways to categorize our digestive tract disorders that you can see on the screen. But we talk about things like erosion, inflammation, and infection. Those kind of things can all go together because they have somewhat similar pathophysiologies. On the other side, you have tumors, both benign and malignant, obstructions, malnutrition, and malabsorptions. Really, you could really argue that obstruction, malnutrition, and malabsorption kind of all go together because they impact the ability for substances to move through the digestive system or are related to the digestive system not functioning in the correct way to bring nutrients into the body. But tumors can also cause obstruction. Obstructions can lead to malnutrition, especially if they're not like a complete obstruction. So, first thing we're going to talk about, temporomandibular joint disorder. Remember, the TMJ is the joint between the maxilla and the skull, specifically the occipital bone. It allows the jaw to open and close, with the primary muscles of mastication being the mediolateral pterygoids, as well as the masseter and temporalis. Those muscles are sometimes key in causing this dysfunction, but also this joint is actually, despite being so simple, it's actually very complex. It has a meniscus, similar to how the knees do, and the meniscus actually has to slide as the jaw moves through its motion. So there can be things that happen to that meniscus, similar to what happens in the knee, where it can fold, it can tear, it can do all sorts of things. That can also be another cause. You can also get arthritis of the TMJ. In general, though, the TMJ disorder can cause issues with being able to actually chew food. Chewing a food is essentially one of the first two processes for the consumption of solid food products. Chewing is key for mechanical digestion, and it's important to chew food properly and thoroughly in order to allow for more efficient absorption and digestion and absorption. Like I said, though, the most common cause of this is a unbalanced activity of the jaw muscles. Typically, one side will be stronger versus the other. There's also things like arthritis that can cause problems. There are, treatment-wise, essentially what is a splint that can go in the mouth to help offset some of these imbalances, and there are rehabilitation protocols that exist, essentially exercises for the jaw, and there's also things like manual manipulation of the jaw that can help as well. In general, though, dentists and other related specialists, like orthodontists, etc., are typically the primary individuals that treat these conditions. So another thing to mention is a tooth abscess. Tooth abscesses can be, a lot of people will feel pain directly in their mouth, but because this often does involve, because it is an infection and the bacteria can sometimes affect the nerve root of the tooth, that will actually lead to pain referral patterns. So sometimes people with a tooth abscess think that they have an ear infection, or they think that they have a headache. Okay, it's one of the main reasons why it's important to do proper dental work and have proper dental evaluations periodically. In general, though, here, antibiotic therapy and then a root canal to remove the infected tissue. Oftentimes, they seal that system off and then will potentially do things like put caps over, or even completely remove all of the tooth structures and place in what's essentially a fake tooth. Oral cancers, these are important to mention. They're most commonly squamous cell carcinomas, but because we do have glands, and quite a few glands in and around the oral cavity, there are also the possibilities for adenocarcinomas. Typically, this is associated with things like smoking, alcohol, even non-cigarette type tobaccos, like snuff dipping. Those guys are a massive, massive, massive number of cases, but human papillomavirus that we talked about as a potential causative factor for cervical cancer is also a causative agent for oral cancer as well. Treatment-wise, like all cancers, depends on the stage. Unfortunately, a lot of people put off examinations of lesions in their mouth. Because of that, oral cancer has a 5-year survival rate of less than 60%. This is unfortunate because oral cancer is typically relatively easy to treat. It's generally very easy to access surgically, and sometimes people do not even need radiation, and it's very unfortunate. A lot of times afterwards, of people letting this lesion kind of fester, they finally say, okay, this is starting to cause real problems. Get it looked at. It gets biopsied. They have cancer. They find out that it has metastasized elsewhere, or in worst case scenarios, the tumor itself has essentially bound itself to important structures, especially vascular or neurostructures, because we don't often think about it this way, but the nerves that supply the diaphragm, which is the most important muscle for breathing, they actually pass through and next to a lot of this stuff. If there's metastasis to where those guys, the phrenic nerve is specifically what it's called, and it arises from cervical levels 3, 4, and 5, little saying, C3, C4, C5 keeps the diaphragm alive. If they get encased in the tumor, they typically won't be able to remove the tumor. And the same thing happens when it encases vascular structures, especially the carotids, whether it's common, internal, or external carotid, and even some of the major veins. It makes surgery much more difficult or even impossible. So next, very common condition is gastroesophageal reflux disease, or GERD. With this condition, you get regurgitation of stomach acid up through the lower esophageal sphincter. When GERD is chronic, it can lead to some damage to the tissues just upstream, which is why you can see dysphagia and erosive esophagitis. Also, if it is bad enough, the reflux can actually reach the oral cavity, which leads to decay in teeth. So what you see here, quick little example. This is very common. Typically, people feel like a burning sensation. It might cause coughing. But one of the main things that we can know that it's GERD versus something else going on, because again, sometimes it's confused for things like heart attacks. People will go to the emergency room and think, "Oh, I'm having a heart attack." Actually, it's acid reflux, essentially. For a lot of people, though, this can be treated without any medications. So things like elevation of the head while eating, maintaining a elevated sleeping position so that essentially the acid reflux would have to fight against gravity, which means likely not getting as high into the body. And even eating smaller meals. Now, antacids are one of the primary ways to treat this, and this includes things like proton pump inhibitors and the hydrogen related drugs, but those actually can predispose people to other problems, especially things like H. pylori infections, which we'll talk about shortly. So Barrett esophagus is the continued changes that occur in the lower esophagus due to individuals that don't deal with their chronic reflux. You get a conversion of the squamous epithelium at the distal esophagus to where it goes from stratified to columnar epithelia. This is called metaplasia, and metaplasia is one of the key steps of developing cancer. Okay, so you basically get a cell changing its shape, which means that there is clear DNA damage to those cells. And with how quickly squamous epithelia divides, this can end up developing into cancer. About 15% of people with chronic GERD develop Barrett, and only about 1% will go from Barrett to a cancerous condition. So, gastric and duodenal peptic ulcers. We really see two primary causes of these guys. NSAID ingestion, so your non-steroidal NSAID drugs. There are COX enzyme inhibitors. There's cyclooxygenase 1 and 2, if they're non-selective, like the ones you often get over the counter, like ibuprofen. COX 1 and 2 are very important for controlling inflammation, but COX 1 actually plays a key role in the development of the protective layer that lines the stomach that prevents the stomach acid from eroding away the actual stomach itself. So you can see how that's a major problem if you're ingesting too much NSAID. You get a downregulation of the protection of the stomach from its own acid, and you can have problems there. Now, another common cause for these guys is Helicobacter pylori infection, or H. pylori. It's a type of bacteria that actually really lives in the proximal digestive tract, specifically stomach and small intestine. It is very resistant to our stomach acid. It actually likes highly acidic environments, and so if you're taking drugs like the proton pump inhibitors that I mentioned before for GERD, it's going to predispose you to an increased rate of these ulcers. So, as I mentioned, you get a breakdown of the mucous membrane. That is either because the membrane was never made properly or there's a bacterial infection. Ulcers are most common in the duodenum in younger individuals, so anywhere from about 30 to 50, whereas the gastric ulcers are typically reserved for individuals that are much older. Those are people that are 55, 70 years old. But it's important to note that anybody can realistically develop these. So you can confirm this with a barium radiographic film, which is basically you're taking an x-ray after somebody drinks a liquid containing substance, containing the substance barium. Barium is a radiopaque substance, meaning that when you ingest it, it is essentially a dye on the radiographic films, and you will actually look for things like filling defects in the stomach and duodenum as it goes through the body. They often will take a couple quick series of these x-rays as it passes through, looking for any potential defect. They can also do certain things like scopes, etc., where the person has a scope inserted down the esophagus through the stomach, but that's typically not needed in this case. To help prevent these things, though, we often, again, control NSAID and aspirin use, but alcohol is also another thing we haven't mentioned quite yet. So acute appendicitis, both acute and chronic appendicitis are inflammation of the appendix, but acute appendicitis is the thing we really have to worry the most about. The appendix kind of hangs off the area of the large intestine called the cecum. So right where the small intestine joins the large intestine, that's the cecum. It's that enlargement that's available. You can see it here on the picture. The appendix kind of dangles off of that. Now, the appendix can vary a lot in its location. It doesn't necessarily have to hang off the inferior side of the cecum. In teaching gross anatomy classes, which are, cadaver-based anatomy, we find some individuals have had no history of an appendectomy that we know of, and we don't even find an appendix. And in other people, the appendix is actually, on the posterior side of the cecum. I've even seen a couple times where the appendix is actually hanging off of the small intestine on the proximal side of the valve there, which is very different. But diagnosis of acute appendicitis is actually pretty easy. Patient's going to have pain that typically starts in the epigastric region and migrates to the lower right quadrant. They often have a fever, a rather severe fever, especially if the appendix has ruptured. They'll have tenderness over a region called McBurney's Point, and McBurney's Point is approximately halfway between the anterior superior iliac spine and the umbilicus. Okay, so you're about inch and a half diagonal between those 2 points. And the test that really gives you clinical suspicion for this is actually very easy. You push in on the spot and you release quickly. Person will often have excruciating pain. They can also typically have pain when you press in and compress the opposite side of the abdomen as well. So next thing to talk about, hiatal hernias. So this is a defect in the diaphragm. So your diaphragm has two primary pathways through it, or I guess I should say passages. And one is for your esophagus, and the other is for vasculature. Okay, your aorta and vena cava. Now, when you have a hiatal hernia, part of the superior portion of the stomach has actually slipped up through that normal passageway. This causes all sorts of issues because there's the diaphragm itself has a specialized, has a couple different components to it, and when they come together to form these holes, the official term for those is called crus. It's still the diaphragm muscle. So as the diaphragm's contracting, it's causing compression of the stomach. And it's potentially leading to increased rates of acid reflux. You're getting issues with digestion. It's not very good. But Luckily, it's relatively treatable. You avoid intra-abdominal pressure. In more severe cases, you might use medications to control the level of acid in the stomach, get it lower. Dietary modifications, so again, eating smaller meals, etc. In very, very, very severe cases, though, they can try surgical repair of that hiatus that it goes through. On the other hand, abdominal hernias are when organ tissue protrudes through an abnormal opening in the abdominal wall. Typically, this is bowel tissue. One of the most common places we see it happening is the inguinal canal in men. It can also happen in women, though, because the inguinal canal exists in women as well, but it kind of loops back around into the body in order to hold the ovaries in place. Now, this can be a major problem because these things can become compressed and strangulated. So that could potentially lead to necrosis and death of the tissue. A lot of times, it's important for the person when they know that they have this to regularly have their bowel sounds checked. Bowel sounds, interestingly enough, have a fun name called borborygmi. And you want to make sure that the bowel is still functioning and moving things along, because this, again, can strangulate the bowel and cause a obstruction, and both of those things are life-threatening. So Crohn's disease. This is one of our chronic inflammatory disorders of the GI tract. I would call it kind of rare. About 500,000 people have an actual diagnosis of Crohn's disease. Any part of the GI tract can be affected with Crohn's, though. And that separates it from a lot of our other GI disorders. Patients with Crohn's, though, they have chronic diarrhea, severe abdominal pain that's often cramp-like in nature. They can develop obstructions at a much higher rate, and they can even experience malnutrition, because remember, diarrhea basically means substances are moving through the digestive tract at too quick of a rate. So things will not be absorbed correctly, and you end up ingesting food that essentially has much lower nutrient content because of that. Another thing to mention is that Crohn's disease can mimic other GI conditions, especially things like diverticulitis, ulcerative colitis, and even appendicitis, which is very different, as we've already talked about. They will do radiographic studies to help differentiate this from other conditions, typically either through things like a barium swallow or a barium enema, though there has been a recent technology advance where we have incredibly high detailed CT scans that have started to become more common and used to examine the digestive tract. So I imagine that will become more common in the future. A lot of these individuals this is typically considered an autoimmune condition, but there are potential genetic causes as well. And so currently the treatment only is focused on symptom prevention and reduction in flare-ups. Now, ulcerative colitis is one of the other chronic inflammatory bowel diseases. This one, though, affects the mucosa and basement of the mucosa in the rectum and colon only. It's often intermittent, but it does have bloody diarrhea, abdominal cramping, urgency to defecate, and a lot of mucus in the stools. The most common onset for this condition is younger. Typically, you start to see symptoms starting between the ages of 15 and 30, whereas individuals that become older and into what is considered medically as geriatric, they typically are going to be pretty safe from the condition at that point. This can be very dangerous. There can be tearing of the rectum and colon that occurs with a lot of blood loss. So it's important for these individuals to have a good idea of how much blood they actually lose. Sometimes in severe cases, they will do surgery to remove the colon or rectum. They call that a proctolectomy. Sometimes with that as well, well, not sometimes, but what they will do is in ilioanal anastomosis. So once they remove the colon and rectum, they'll actually connect the ileum, which is the final portion of the small intestine, and they'll connect that directly to the anus. Which again, that has potential risks for things like malnutrition, because the large intestine and small intestine have slightly different functions, and different things are absorbed in different areas because of that. So a lot of times these people have to take vitamin supplements, etc. Gastroenteritis is just the generic term for inflammation of the lining of the stomach and intestines. You often see a loss of fluid, dehydration, and disruption of electrolyte balances, which is why you see all of the symptoms here. Typically, this is caused by bacteria or parasites, so the most common treatment is going to be the antibiotic therapy, but you're going to supplement that with antidiarrheal agents to help slow down loss of fluids of the body, which is, again, diarrhea is the quick movement of fecal matter through the digestive system. And if we need our digestive system to absorb the medication, you also get reduction in effective dosage to the body. So slowing down diarrhea is a key part of treatment for that purpose, as well as restoring your fluid and electrolyte balances. It is also possible for people to develop this condition if they eat food that is has much more capsaicin, so spiciness, than they're normally used to. Alcohol, caffeine, and NSAIDs also can all cause this as well. So intestinal obstruction, we have already kind of talked about this. It can be partial or complete. It's important to monitor electrolyte balance and white blood cell count, but borborygmi, so the auscultation, is also an important part. So typically this is going to be a mechanical obstruction. So there's so many different things that can mechanically lead to obstruction of the GI tract. You have intussusception, which is typically seen in young children. We've already talked about herniations. Adhesions can also occur, but intussusception is kind of where the intestine, how do I describe this? It kind of rolls inside of itself. So it's like if you have a suitcase and you have an adjustable handle on your suitcase that allows you to, walk upright while rolling it on the ground. That's essentially what happens here. It's the same idea as you're folding away that handle on your rolling suitcase. That happens to the intestine. And then there's also volvulus, which is basically where the intestine rolls the other direction on itself and strangulates itself. The treatment of this, there are some conservative measures, but generally surgery is performed. They often have to remove the diseased bowel, so ostomies may be needed as well. Some of these individuals have a severe enough issue that they end up with a colostomy bag implanted. So it can be rather dangerous. So diverticulosis, it's important to get this concept because diverticulosis is different than diverticulitis. So diverticulosis generally has no symptoms. What you're seeing here, these little enlargements, those are diverticula. Okay, so they're like ballooned little pouches of the intestine. Diverticulitis, on the other hand, is when there is an infection of a diverticula. Okay, so this is a true problem. Now, with a diverticula, it does predispose. You have to have a diverticula to have diverticulitis, right? But the diverticula essentially is that enlarged outpouching, and it typically has a somewhat narrow opening. So when stuff gets in there, it's hard to get it out. So with this, you often see a lot of your pain and tenderness, fever. Your white blood cell count is going to be elevated. This is normally bacterial in nature. Typically, when food gets lodged into one of these diverticula, the bacteria absolutely love it. They start digesting it, etc. Treated with antibiotics, stool softeners, and liquid diets. In very, very severe cases where the infection cannot be controlled or bowel perforations occur, surgical resection may be indicated. Just a quick mention for colorectal cancer. Again, this can arise in any part of the colon. In old patients that develop iron deficiency anemia or their stool is positive for occult blood, this must be examined for. There are some genetic predispositions to this, but this is really the primary reason why we end up looking for people to have their colonoscopies, because you want to look for the adenomatous polyps, because polyps are essentially the precursor to colorectal cancer. Now, polyps do not mean a person will develop colorectal cancer. It's the same idea as we talked about Barrett's esophagus. You have a metaplasia, which is a change in cell type that causes the formation of those polyps. Another generic thing to mention, symptom-wise, is something called ascites. You basically get an increased retention of fluid. This can also occur not just in colorectal cancer, but in a lot of liver diseases as well, like cirrhosis. So colorectal cancer, treated similar to most other cancers. You'll resect the affected tissue when possible, and you may even perform chemotherapy or radiation-based therapy. Irritable bowel syndrome is a syndrome characterized by chronic abdominal pain that's going to include discomfort, bloating, distension of the abdomen. All of those things are super common. This is generally a younger person's condition between ages 20 and 40, and females are much, much more likely to develop this. There is a known risk, though, of any gastrointestinal infection leading to this developing. So there are some probiotics that can be taken to help with this. You want to use soluble fiber supplements, which are probiotics, and there's also, those are prebiotics. Prebiotics are the food for bacteria, which bacteria love fiber, and probiotics are the bacteria themselves, things that, often are supplemented into substances like yogurt. IBS generally does not, it's typically not a life-threatening condition or anything like that, but it does lead to potential massive quality of life problems. One of the more interesting things you might see is medication to block the 5-HT3 receptors in the gut. That's actually a subtype of serotonin. 90% of the serotonin in the human body is actually manufactured in the digestive system. And if you can, there is some links between the function of these specific receptors in the gut and irritable bowel syndrome. So it's very interesting. Next, cirrhosis of the liver. This is degenerative disease of the liver, essentially. So we've talked about a lot of different degenerative diseases that we've seen. There's a wide range of different conditions, but you typically find that there's a large increase in the liver. Malnutrition, environmental chemical exposure, alcoholism, which is the most common cause of this. But there's even other things such as Wilson's disease and hemochromatosis, which Wilson's disease is a problem with the processing of copper in the body, and hemochromatosis is a problem with the processing of iron by the liver. So rather interesting conditions, because hemochromatosis is actually treated by blood donation, and then Wilson's disease is treated with substances that bind to copper to help remove them. Wilson's disease is actually cool because it results in the deposition of copper in the person's eye. So they'll actually have rings of copper in their eye that have naturally been put there. Next thing to mention is cancer of the liver. Most common type is hepatocellular carcinoma, or HCC. This is going to present in a very similar way as any other chronic liver disease. Typically hepatitis B, but any of the other hepatitis conditions can also help contribute. But cirrhosis, hemochromatosis, etc., all of those things are all very, very, very important. And this is why hepatitis B vaccination is so important. Next is a very common condition I'm sure everyone has heard of before. This is cholelithiasis. This is gallstones. Gallstones cause obstruction of the biliary ducts, which we'll see on the next page. But generally, when you're looking at laboratory values for this, you're going to show elevations in bilirubin, ALP, AST, and ALT. All of those are liver enzyme levels, and they're going to be affected because of this backup. It can be incredibly painful, and nausea and vomiting are not all that uncommon to occur. So when we're looking at this diagram here, we can see the gallstones building up in the gallbladder. These stones are specifically typically related to cholesterol, but there are different substances that they can be made of, especially when they start to calcify or solidify. So you have your cystic duct here. You have your left and right, or right and left, I should say, hepatic ducts. They join together. That's your common bile duct right there. And that then joins with your pancreatic duct to be released into the duodenum. These stones can get caught anywhere along your cystic duct, common bile duct, or even into the duodenum itself, which stops the release of bile. And remember, bile is incredibly important for the digestion of fats. So this is what these actually look like inside of the gallbladder. So ultrasound is pretty much the gold standard for identifying these, because they're not always solid, so they're not always seen on X-ray. There are medications like the chenodeoxycholic or ursodeoxycholic acid that can be taken to help dissolve gallstones, especially in patients that are very ill and can't undergo a surgery. Fatty intake is typically associated with this, and if an individual has a high level of recurrent liths, they will remove the gallbladder. And fat in the diet definitely needs to be controlled once the gallbladder is removed, because remember, again, bile dissolves fats. So next, again, cut back on fats. Typically, these people will have the pain shortly after eating. So next, acute and chronic pancreatitis. So these can be, the pancreas is often a very misunderstood organ because it has so many different functions. It obviously plays a role in our metabolism by regulating the two primary hormones of glucagon and insulin, with glucagon being made by the pancreatic alpha cells and insulin being made by the pancreatic beta cells. But there's also other cells in the pancreas that make pepsin. Remember, pepsin is a key substance in the breakdown of proteins. So when we're talking about pancreatitis, we're really talking about disrupted regulation of a little bit of all of that, but primarily the digestive side of things. Acute pancreatitis both of these can actually really be life-threatening. They can lead to changes in blood pressure, etc. Chronic pancreatitis is typically not as severe, and it's often very vague. A lot of people will have complaints of back pain. So it's important to differentiate out your generic mid to low back pain from chronic pancreatitis. On the other hand, acute pancreatitis is always life-threatening. Individuals can have, sudden severe weight loss. You might even start to develop diabetes, etc. When the pancreas is acutely inflamed, the pancreatic enzymes basically seep into surrounding tissues, which will lead to the digestion of those surrounding tissues, which is obviously not very good. Gallstones are actually the most common cause of acute pancreatitis, especially when they're blocking the pancreatic duct. Chronic pancreatitis is typically alcoholism. So individuals with that need to pay close attention to the level of alcohol that they intake. Another thing to mention is pancreatic cancer. This is normally an adenocarcinoma because the pancreas is a gland. Specifically, adenocarcinomas are for exocrine glands. And it typically occurs at the head of the pancreas. Pancreatic cancer is often very dangerous. It can be very aggressive, and prompt treatment is necessary. Unfortunately, it often has very generic presentations and is often not pursued as a potential diagnosis early enough. Even with resection of the pancreas, the 5-year survival rate is less than 25%. A big reason for this is less than 20% of the patients that actually get diagnosed with pancreatic cancer are no longer candidates for surgical resection. So malnutrition is a generic category of disorders. There's different types, as you'll see on the next page, but basically the body is unable to absorb certain substances. So 3 very common types: kwashiorkor, which is inadequate energy in general. Marasmus is a combined protein energy deficiency, and protein energy malnutrition is just, again, a decrease in energy and protein consumption with a increased nutrient loss. We see these things in different populations. Kwashiorkor is typically related to acute illnesses, while marasmus is typically more chronic conditions. So this is showing you what people with protein energy malnutrition look like. They have significant muscular atrophy. So really, treatment is based on the underlying cause. There are other diseases that are related to malnutrition. When you talk about things like vitamin B12 deficiency leading to anemia, right? That's technically another form of malnutrition. So you really need to try to adjust the underlying cause. Another thing to mention is that malnutrition can be the result of a psychiatric condition, any of the eating disorders as well. Hypervitaminosis is a major thing to also mention when we talk about the fat-soluble vitamins, A, D, E, and K. These vitamins are different than the other ones, like your B vitamins, vitamin B, vitamin C, etc., because they get stored in adipose tissues. So each of these different things have a potential to be very dangerous. Now, one thing to mention is that it does typically require a very severe increase in these vitamins. For instance, vitamin D is almost impossible to experience hypervitaminosis in. The average individual is actually vitamin D deficient, so it's very, very tough. And a lot of times, supplements for vitamin D, you could take 3, 4, 5 times the amount that's on the bottle, and you're still not coming close to a level that's going to experience toxicity. However, one interesting fact about vitamin D is that granulomatous diseases like sarcoidosis actually can cause essentially synthesize their own forms of inactive vitamin D that then get released into the body and can actually become activated. So people with conditions like that need to have close monitoring of their vitamin D levels. Vitamin E overdose is able to interfere with vitamin K, and vitamin K is important for clotting. It's a major, specifically vitamin K2. It's a very important part of the clotting cascade, and that's why we actually have drugs that specifically target vitamin K2 in the form of warfarin. Malabsorption syndrome, we've already kind of mentioned this, but essentially any disruption of the components of the digestive tract that lead to a reduction in absorption of nutrients of any kind is a malabsorption syndrome. Typically, they're related to enzymes not being present to break down things. So you could even classify, again, vitamin B12 deficiency, which is typically an autoimmune disease process that relates to the inability to synthesize vitamin B12, which is a key component in red blood cell formation. So that's technically also malabsorption. Treatment, though, you look for the underlying cause and you're going to treat that underlying cause. A lot of these individuals will end up needing vitamin or mineral supplements, though. And sometimes you just only treat with that, because if the body is only able to, say, synthesize half of what you ingest, you just double the amount that you ingest and you have a normal level of it.